Good day, everyone. I'm Pooja Joshi, your host for today's episode. In this session, we focus on a condition that is common yet often misunderstood: irritable bowel syndrome, or IBS. To help us navigate this important topic, we are joined by Dr. Mashkoor Ahmad Beigh, gastroenterologist, GMC Anantnag, Jammu Kashmir, a respected expert in functional gastrointestinal disorders. Today, Doctor will walk us through early symptom recognition, simplified diagnostic approaches, and effective evidence-based management strategies for IBS in routine clinical practice. Doctor, thank you for being with us. Let's begin our discussion.
Hi, I am Dr. Mashkoor Ahmad Beigh. I have done my MBBS from GMC Srinagar. I did my MD from Sikkim Sora, and I did my DM gastroenterology and hepatology from Sikkim in 2017. Currently, I am associate professor in charge head Department of Medicine in Government Medical College, Anantnag. I have been practicing gastroenterology for last almost more than 15 years.
So, doctor, question for you is, what exactly is IBS, and how would you describe it in simple terms to a non-specialist?
IBS is basically a very common problem in gastroenterology. To a very common man, it means a very disturbing, smoothing abdominal pain, and that pain associated with either a constipation or diarrhea, or sometimes mixed together. If this occurs for a long duration, then it qualifies, and there are we describe some alarming signs. If they are not there, then it qualifies it for irritable bowel syndrome.
Why do you think IBS remains one of the most underdiagnosed gut conditions in India?
We see this condition. It is not very uncommon, but very common problem. It doesn't cause any mortality or any serious things, but it makes the life of a person uncomfortable. He cannot take this type of food. If he gets some sort of stress, there are symptoms. So it is a thing which is common in our society. We see in a gastroenterology practice, our 30 to 40% patients have symptoms of irritable bowel syndrome. It is why there is no specific parameter we can diagnose it. But now I have clinical diagnosis like that: a pain with either loose motion or constipation occurring for long duration without warning signs is qualifies for IBS. Next.
What are some common mistakes in diagnosing IBS at the primary care level?
That IBS, we told you that it is a smoldering chronic process which gives a very disturbing thing to a patient. So it is not a basically is a chronic problem. The mistake a physician is doing is that we have, when we talk of the irritable bowel syndrome, we have to exclude the things which mimic such an illness. So we have to some red flag signs, we call them. Say, for example, any patient who has loose motions and he is associated with blood, so it cannot be IBS. A patient who is having constipation with bleeding cannot be IBS. A patient who is having a significant weight loss with loose motions is a problem. It is not IBS. A patient who is having severe anemia and associated with gut symptoms like pain, loose motions, constipation is not IBS. So we have to differentiate IBS from a serious problem. So these are some of the things: weight loss, anemia, bleeding, abdominal pain to the extent that he needs an immediate analgesics like going to hospital midnight and taking medications for that from the hospital, injectable. Though these cannot happen in IBS. So we have to educate our clinics, our physicians, primary physicians, that if such things occur, then IBS is unlikely. So we have to exclude those important reasons to have an IBS. And then IBS, we know that if we exclude those causes, then IBS, we have to reassure the patient. We have to give him confidence that because they are disturbed by their symptoms. If we reassure them, we give them confidence. Sometimes medicines, but majority of the things is the reassurance and some dietary changes that help.
Once IBS is diagnosed, What is your first line approach to management?
Absolutely, it's a very common thing we come across in our daily practice. One important thing is if we are sure that now we have excluded the common mimickers of the IBS, then we have to reassure the patient. That's very important. We have to give him confidence that these symptoms are not serious to his life. Because why we are seeing these patients, they are very anxious. They go to multiple people simultaneously. They consulted in it. Sometimes in a day they consulted two doctors, sometimes three. Wherever they find any doctor that they go there. So we have to reassure them that your problem is not serious. If we get the confidence of the patient that it is not a serious problem, then things go very smoothly. And there are other management lines depending upon the severity of symptom. For me, reassurance to the problem is very important.
What's your opinion on the role of rifaximin in IBSD? Where does it fit best?
Yes, when we talk of diarrhea problem and irritable bowel syndrome, yes, there is a good role of multiple things. We do probiotics. We ask them to refrain from some foods. And rifaximin plays a very pivotal role in irritable bowel syndrome diarrhea problem. We usually give it, if patient, we reassure them, we give some diet modifications. We call that as a no food map diet. Means they have to curtail the intake of simple sugars, these junk foods, less of pulses, some fruits, and dairy products. So we reassure them, and then if they are not getting control with that, then comes the role of drugs in the form of rifaximin, very pivotal role in the treatment of IBS.
How do you handle a patient who doesn't believe IBS is real?
Yes, that is what is important thing. That I told you that it's a very common problem, and these patients are very anxious. They do doctor shopping, they go here and there. If a doctor convinces them that this is definitely a problem, but this problem is not going to kill you, is not going to do you harm. But yes, they are very anxious. So it is important is the education about the thing, what really happens. If we explain them what really happens to their gut in IBS, majority of the things will be sorted out there on. But yes, there are some resistant cases where people who have IBS with constipation, people who have diarrhea, they sometimes need multiple drugs, including the dietary management.
What advice do you give to patients for long-term gut health and relapse prevention?
Yes, now one is important, we reassure them. Really, their stress part, that is one important thing. Second is, we know that diet modifications must be, the concept is called a low food map. Means we have to give them like simple sugars, they should be avoid them, dairy products, they should avoid some fruits and pulses. It's a very long term. They have to get control over these things, and that is what makes them a good thing for them. Reassure them, diet modifications. Maybe sometimes we may ask them to go for exercise to get rid of them, because what important in IBS is that they are always thinking about their belly, they have their stomach, about their intestines, everything. They leave everything to it and they just think about everything about it. If we reassure them that this is not going to be a problem, some diet modifications, some medicines, then that this prevents their relapse, as well as that gives them a confidence, and they take over out.
What do you wish every consulting physician understood about IBS?
Yes, our colleagues should understand that these patients, we should not just say them they have some thinking problem. We refer them to psychiatrists. No, they have issue with the gut. Only our thinking is that we have to recognize this problem and reassure the patient. If the important is that we have to exclude the mimickers of IBS. We have to rule the IBD. We have to rule out the celiac disease. We have to rule out some organic causes like malignancies, other things. If we exclude those things, history, sometimes investigations, and then we have to reassure them. And we should not label patient IBS unless we have exclude those red alarming signs, anemia, other things are there. So if it is there, then we may counsel the patients and then they do fine.
One food you tell IBS patients to avoid?
I can't say one, but yes, sugar is a very important thing. I will ask them sugars and pulses. Majority I will ask them this sugars and pulses. They have to avoid.
What's your gut-friendly morning habit?
Yes, I prefer usually in the morning to have a curd. That gives a very good thing, and I usually take curd is one of the favorite things which we take. I take a lot of things also, but and the avoid I which we avoid is the sugar. I avoid sugars. I hardly have taken sugar for last 3 months. Yes, curd is a very gut friendly thing. I always encourage my patients to take curd also, yogurt or curd. Thank you very much. Thank you for watching me.
Thank you, doctor, for sharing such valuable insights on IBS. Your clarity and practical guidance will certainly help both physicians and patients approach this condition with more confidence. To our listeners, thank you for joining us. Stay tuned for more expert-led conversations. Until then, take care and prioritize your gut health.